started. My name is Carey Matsuba. For those of you who don't know, I'm one of the pediatricians in the Division of Developmental Pediatrics. I am in the back hallway. I have no office space, so I sort of am isolated significantly around the orthopedic surgeons. And I wanted to present something that would be tapeable. And so I needed to know a little bit of my audience. And one of the things that keeps coming up over and over again for me is this real challenge that we have in how we define things. And I see it over and over again. And so I'm going to bring it here in a very informal discussion. And so hence that if you know me, I'm always in shorts and t-shirts. So that's my informal discussions. Okay, so let's see it. Oh no. Page down. Oh no, it's not that. I don't need that. Oh, okay. Okay, here we are. This is our land acknowledgement. We offer this time to acknowledge that Sunny Hill and BC Children's Hospital are located on the traditional, shared, unceded ancestral territories of this Musqueam, Squamish, and Tsleil-Waututh nations. So I'm pleased to be here to present this information. I have nothing to disclose. Okay, so this is the objectives, and I'm going to really focus on the first aspect of the definition, the definition of visual impairment. It's in part because it is such a loaded diagnosis. And how do I know it's loaded? One, I know it from the referrals that I receive. So I get referrals from a whole bunch of different people because, in fact, there's a functional problem, but whether it's visually impaired or not depends on a perspective. We're going to talk a little bit about the causes. Again, the causes of visual impairment can be really vast because it then depends on the definition. And then a little bit on the strategies, which is not as controversial, but there are some challenges about what are we trying to do. And so if you know what this picture is, this is the traditional picture of 7 blind men touching different parts of an elephant. And this is the perspective you have. So when you're coming in and you're seeing a patient, which perspective are you choosing? Are you a holistic person? Which I would argue that many of us are not. We're really focused on what we do. And we do it all across pediatrics, whether you're a cardiologist or an intensivist, or even within our division, because we focus on the problem that is presenting, which is sometimes a problem, because then we're going, well, you might have the problem, but then what is the functional consequence, or what's the developmental issue? So I'm going to ask you, what is the definition of visual impairment? So I can search and I can look at a whole bunch of different information, but you know, when all else fails, look to Wikipedia. And this is true. This is the true definition of visual impairment. So if I were to look at studies of what they are trying to talk about in terms of visual impairment, and it's somewhat medically based, because it's important that we use that term, it's in healthcare. It will talk about reduced visual function that cannot be improved by the use of glasses, surgery, or other medical methods. So that is the true definition, right? So then anybody who has astigmatism, if you have astigmatism, do you know that it's very difficult to get 20/20 vision in astigmatism? So are you now visually impaired? You could be. This is the definition of visual impairment. It could be. So then I would ask this one question. What is visual impairment to you? Because what is to you has to align with what is to me if you refer to my clinic, and then that's how I make the definition. Now, I will argue that blind, we probably are in the same boat with if you're no light perception vision. everyone would argue, say, hey, you know what? You're visually impaired. But if I were to use the term severe, moderate, mild, or even normal, I would ask you, is your mild the same as my mild? So what is your cut point for calling someone visually impaired? What is it? And so we see this all the time. I review papers and I go, boy, what is the cut point they're using for being visually impaired? I can see how it might be visual impaired. What is the measure they're using? What is the age? What was the environment? What was the circumstance to call that person visually impaired? So then I'm going to ask you, how many people are normal? And that is such a loaded question talking to people that deal with developmental peds, because you use standard deviation curves or percentile curves. So you're apparently normal if you're above the 5th percentile. Doesn't mean whether you're functioning appropriately or the 10th percentile, or if you're DCD, you could be at the 16th percentile and you're perfectly fine, or are you not? I don't know, but those are cut points. This is the challenge. And I get referred and go, oh, well, someone else has said they're visually impaired because you don't send patients to me if you're not visually impaired. But I'm going, well, are you normal? And in the old days, Dr. Jan, Chris Locke's around, so she would know who Dr. Jan is. Dr. Jan used these terms like severe, moderate, and mild, and I used to use them when I was just beginning. And I said, oh yeah, we're just going to use this. And then I started to go, oh, this doesn't make any sense, right? He was a neurologist like you, Ram, or neurologist, but uses terms. And so when you reflect back, and I'm going to ask you over and over again, where is that cut point? And it's difficult because I would argue we don't have good cut points for that. I've lost my little slide advance. Okay, there we go. So I'm going to go and ask, if we have some criteria for visual impairment, I'm going to ask you, what are the visual functions? Does anyone know the visual functions? Does anyone? Anyone? Scott? Anyone? Yeah, only the people that are young know who this person is. Does anyone? Can someone just list one?
Light perception.
Light, that's one.
Color.
Color?
Peripheral vision.
No, that's the number of retina cells. But that's important. No. What does the retina cell see? What does a retina cell see? Sorry, what did you say, Ram? Movement. Contrast, white to black. And then there is a specific thing where two retina cells from one eye versus another eye meet, and it's called stereopsis. So one cell sees 5 ways. That's pretty remarkable. Like, you tell me another neuron that does 5 things. So we have 5 functions. So now in the realm of impairment, you should have technically an impairment in any one of those reasons. And we could say, hey, you know what? You're visually impaired. You've got a problem with color vision. You should be visually impaired. You have a problem with stereopsis. You should be visually impaired. And so if we have these 5 things to look at, you go, oh, well, how come Dr. Matsuba doesn't see anyone with a lack of stereopsis? Well, if I started to see patients with a lack of stereopsis, I'd have a waiting list longer than autism, right? I would, because look at 1 in 20, 1 in 50. It's a huge number, right? Just color deficiency, males, I would be busy. So, but that's an impaired function. And that's one of the problems that we have. You have a problem. It's an impairment. We don't call it that way, though. So there's other ways that we define visual impairment. We can identify it by physiologic condition or structure, by function. But funny enough, there is no standard definition in Canada. Matter of fact, I would argue in the world for anyone who is under age 6. And that's because of one reason. And does anyone know what that one reason is? That doesn't work with me? That vision develops over time. So when you're born, you have light perception vision, or that's all you need to have. And sometime between that, you hit visual maturation. And that's why if you go to ophthalmology clinic down this hallway, why they're busy is that the vast majority of patients, they're working on issues with alignment, trying to improve the vision in the other eye, typically by patching. So that's what they're trying to do. We have no standard definition. So that's really important to know. So for the past 20 plus years, I've been just winging it, right? I'm making the determination, are you visually impaired? Yes, no, I have no definition, I'm just gonna call it, right? And so that is a huge challenge. So if we change the page, we just forget about physiology and we look at, oh, well, we can also define, or some people have defined, problems with vision related to function. This is a huge problem, but because they are huge problems. You can have a problem with reading, a problem with mobility, written output, with how you interact, all related to vision. So it's not unusual that I might get a referral for any one of these reasons because you have a functional problem. It's an ability to do something. So I can get those referrals and I'm sort of going, oh, well, is it truly a visual impairment? Yes or no? Who defines it? And just remember, all these problems are much more common than if I were to use a thing like reduction in visual acuity. So what do we do? So I'm going to tell you what we do is that we, over a period of time, winged it. We winged it because most things are in how our forms are filled out are based on ICD. That's what we did. We winged it. If I looked at vision support services in school, 2 of the 3 criteria follow ICD, and then they have a functional criteria, which I don't know how to answer because I can make everybody functionally visually impaired, right? But the ICD follows 3 things. You've got to have a problem with visual acuity, which is a mixture of light and contrast, or visual field, so how many retina cells are firing. You have to have a reason for that problem in the visual pathway. So none of you can come to my clinic and say, you know, I've got Royal College exams tomorrow, but I've all of a sudden can't see. Can you write me an accommodation? Right? Until I find the medical reason for it. And the measurement has to be in a standardized optimal condition under best correction. So that is the standard of why we use. So if we use that standard, all of a sudden my wait list of 3 years goes down significantly because now we're dealing with if this is legally blind, someplace between 0.1 to 1 in 1,000 patients. That's the range that we're dealing with. So in BC, technically, that's 5 to 50, sorry, 1 to 5 patients who will meet criteria for legal blindness if we have 50,000 live births. So it's not so many that come over that period of time. There's a huge range, and this is legal blindness, and then we'll get back to problems with that termination of legal blindness. So when we have an ICD diagnosis, which WHO tries to inform, well, how good is it? Well, the problem is that every country has a different threshold. So ICD has decided that's what it's going to be, and that's ICD is a whole bunch of different countries meeting together to make these determinations. But hey, if I'm in the UK, I'm going to use this, which is different than North America, which is different than Belgium. It's a huge problem in the EU because different countries in the EU have different criteria for legal blindness, which leads to different supports depending on what country you're in and which the EU does not like, right? They want everyone to be consistent. So that's one of the challenges. No one is consistent. That's one of the reasons why prevalences are really challenging, because prevalences are based on what individual countries report. So then you go, well, what do I do? Or what do we do? Well, we never had a lot of criteria before I started this job. And it's in part because Dr. Jan just used to hang out in ophthalmology. And so it was a very ophthalmology kind of world. And that made perfect sense because most of the referrals were coming from ophthalmology in the first place. So, and the primary issue is that we should have a condition. Like, what is the visual pathway condition that leads to whatever the problem in the vision system would be? That's important because if we don't know why, we should find out. In general, we have a condition in the visual pathway that will lead to some level of reduction in visual acuity by the time you're visually mature, which is 6 to 8 years of age. The good news is that most of your vision occurs develops in the first 3 years of age. So that's the good news. And even on top of that, most of the vision develops in the first year of age. So we get a really good idea where you're going early on. But whether you meet the criteria at 6 to 8 is one of the questions. Or the reverse, you may have a condition that might get worse over time, which is really more challenging because these diseases are unfortunately diseases of worry. We identify them, but we often can't do very much about them over a period of time. And so that is a much harder. And so then what happens for these patients is that we tend to follow them over a period of time to just reinforce the worry, like how much change has there been over a period of time. The vast majority of retinal dystrophies, most of them don't really have a functional problem until their teenage years, so I can push them out further and further and further for follow-up, right? So that's one of the really key. But then I always have to remember that I am only one person that has made whatever criteria. There are other people that can determine who's visually impaired. Matter of fact, all of you, no one has, this is what's going to be done in BC, in Canada, in the world. So when you think there's someone's visually impaired, you can honestly say it. There is nothing there, as long as you follow the Wikipedia definition, right? That's true. You got to have a problem with visual function that's not correctable. So that's the real key. And it's a big problem. It's a problem if we don't have a clear definition, because I will argue that I just recently reviewed a paper about habilitation, and they had a patient in their vision system who had a cataract. And the problem about a cataract is that it is a treatable condition. So you remove it, you're aphakic it, they put glasses on, you should see. So how are you visually impaired? And they had 10% of their populations in that rehabilitation study that had cataracts. And I argued, well, how are they visually impaired? And I'm not saying that they're not visually impaired, because anyone can make that definition. I just asked, how did they define that level of visual impairment? And there are ways around it. I've seen patients with cataract who do meet criteria for visual impairment. They're all sad stories. They're usually immigrants. They had cataract surgery. They were never placed in aphakic corrections. And so, in fact, they had nothing to focus the image on the back of their eye. So they actually had bilateral suppression amblyopia. But if you're in a developed country and you have cataracts and you're visually impaired, I will ask you how. And so, but I didn't say that they're not visually impaired. I just asked you what criteria did they make? And there's tons of things that we deal in vision because often how you're defined by visually impaired is based on the measure. And I'm going to talk about measures, but I'm not going to talk about anatomical conditions yet. But funny enough, you're visually impaired often based on anatomical condition. So if you have optic nerve hypoplasia, you're visually impaired. I see a lot of patients with optic nerve hypoplasia that are visually impaired. And I see there's probably about half of the other patients that are not visually impaired that I don't see because they do not meet the criteria according to our definition. But they might meet criteria because, funny enough, most people with some sort of visual pathway problem, they just say, oh yeah, you have a visual pathway problem, you're visually impaired. So measures. The gold standard, in fact, I find interesting, is a behavioral test. The gold standard for vision assessment is a Snellen acuity chart. And it's not the projected kind, it's the paper with a black E at the top. If you all remember that, that is the gold standard. Every type of visual acuity test is standardized to that test. So it's important to know that when you're here in ophthalmology, is that test slightly easier or harder? I'm going to say, if it's done by the ophthalmologist here, it's slightly easier. I can tell you why. They use a television screen like this. So that's light projection. So you're going to get a better view. They also do their lanes in ophthalmology. I don't know how many people have gone to ophthalmology, but the ophthalmology lanes are 18 feet. So that makes it a little bit easier than the standard 20 feet. So it's a little bit easier. Even in my clinic space, if you've been there, that where the chair sits is actually at 17 feet. Because if it was at 20 feet, it would be right by a light source, and that can be problematic. So that's why I've moved it up a little bit closer. So it's a little bit easier, right? So just so you know, there are standards of what we do, and I can tell, does anyone know why 20 feet or 6 meters is used? I gave the talk to the fellows. And there's lots of fellows back here, but without asking the people that work with me in terms of vision. So 6 meters or 20 feet is when your lens is absolutely relaxed. So it's like looking into infinity. So kids, funny enough, when you do things at near, they have an optical advantage because their lenses are so squishy that they get a magnifying component when you do activities at near. And so that's the big difference. Infinity versus whether or not your lens has to squish down. So we have gold standards. Now there's huge problems with the gold standard. Like how do I get a 2-month-old to do a Snellen acuity chart, right? So then again, I fake it all out, done it for 25 years. I just make it up, right? So someone's done studies to try to find models that are both other ways of behavioral testing or electrophysiological testing. So we do behavioral testing. There's really 2 types that are done here. One is the preferential looking acuity cards, the teller cards, and one are Cardiff acuity cards, which are basically a shaded gray picture. Both give you an acuity estimate. They've been standardized to a Snellen acuity test to see whether they match reasonably well on people who are developmentally normal. So that would be the first part. But why do I use preferential looking acuity tests over Cardiff cards? The reason is that someone has done a curve. So I can actually determine where you are on a percentile curve. And I don't really give you the percentile. I just want to know if you are below the 5th percentile, because it makes your risk higher. So if I go back and I say, well, well, you're on the 4th percentile. Oh, you must be visually impaired. By ICD standards, visual impairment in BC probably is running around 1 in 750. So really, I'm looking for someone who's on the 0.15 percentile. So even if you're on the 4th percentile, the chances of you being visually impaired is less than if you're really low. But the anchor portion is that you have a reason to be on the lower limits of the normal. So you're still at that risk that's higher. Right. And plus, then I often in the past, I said visually impaired, was visually impaired. And then I started going, wait, these are just risk factors because, hey, no one knows what your vision is going to be at 6 to 8 for certain. And so then I've changed. What is your risk? Your risk becomes higher the closer you are to that threshold number. Okay, so there are huge amounts of challenges too in terms of how to measure. Because when patients are being seen, you have to think about who they are as a person. And lots of conditions that are vision, if you have one cause of visual impairment, you're more likely to have another cause of visual impairment. You need to have vision at some period of time to measure vision. Because funny enough, vision is developed. You have to practice using your vision to see. And so when I get referrals when you're in the newborn period, I go, oh, well, what is the chance of this child from the NICU having an opportunity to see? Because have you seen what they do in the NICU? The first thing, they put a cover over the isolette and you're sitting going, oh, so that's okay. And it doesn't really matter. They can't see the cover, in fact, because their focal length is like this close. So unless that you're doing like nose-to-nose activity, of which if you follow a NICU nurse, they probably say, don't touch the baby, and you're really close, right? So we're not doing that. Or my funny one is when they put the mobile. You know, the mobile is like 3 feet high, and I'm sort of going, oh, babies can't, that focal length is too far. I mean, it sounds like we're doing stuff, right? And who doesn't like to have a mobile out there? But it's so we have to understand that. Then the next thing we have to do, well, can I measure from 20 feet, 6 meters? Like, what is the impact for me doing a near test? Right. And then field defects that were not great. But the good news about field defects in children, they're most likely going to be some sort of anopia. Because narrowing or tunnel vision, that's a sort of a teenage kind of phenomenon that we see. It's very rare to see that in pediatrics. We can see increased optic disc size because of glaucoma, but functionally, I think I have one patient with bad glaucoma who had challenges in compliance using medications. And even that was borderline, and she was 18. Okay, so the causes. So this will be a little bit faster. There are traditionals, and the way that almost everyone defines visual impairment is by anatomy. And that's easy. It's easy until we can't find an anatomical cause. So that's how most referrals get. I get referrals just because you have an anatomical condition. It doesn't mean that you're visually impaired. So I'll get a referral. For example, I might get a referral for cataracts. And I go, well, you know, how are you going to be visually impaired for cataracts? And you can get them, but it's because they have a syndromic cataract problem. And it may lead to a problem with their anterior chamber, and that might create some problems with glaucoma. And or another one is that you have a developmental disability and you have cataracts, they won't keep their glasses on. And if they can't keep their glasses on, they can't actually focus. And if they can't focus, they can't learn to see. And if you can't learn to see, you have a window of opportunity for them to develop. So they end up with suppression amblyopia. In fact, I suspect we have a lot of patients who have some level of amblyopia because of an activity they're not able to do. So mobility is a real common one. If I can't see a small object from 20 feet away because I can't move to it, I'll start to ignore it. So often some kids with significant CP, they have good, in my mind, visual function. They can identify objects and look at pictures and they can watch video. But if I ever try to do something from 20 feet away, they can't do it. They just won't attend to stuff that is too far away. And so if there's anyone in power mobility, that's a really big advantage. Power mobility makes you look 20 feet away. So we try to look at it. And the ophthalmologists are really good at anatomically defining about 2/3 of what they see, because they can see the optic disc and the fundi, but they're not so good beyond in the optic radiations in the brain. And that used to be more of a problem because we used to have way more HIE in the early 2000s, 1990s. HIE was way more prominent, but it's not as prominent as now. And then the final ones that people talk about visual impairment are these vision association areas, which does not follow ICD. So I tend not to focus on them so much because they're ways that we process vision. Then once I say process vision, I'm thinking higher order types of activities. So what happens if we don't know? What does it mean? Well, that means the anatomical structure doesn't know. And so this is not uncommon because I had a patient maybe a year ago that was seen by an ophthalmologist, and a good ophthalmologist, pediatric ophthalmologist in community, and this patient had no vision, but a normal ocular exam. And in my mind, that comes down to two things. The common things we always hope for would be a thing called delayed visual maturation. So for some reason, the system doesn't kick in. It's a diagnosis retrospectively. So you have to wait until the vision matures and we're all better. But this patient, there's one other cause that sometimes you have to be really astute, because the fundi in general looks normal until you really ask the ophthalmologist, did you look for this? That patient had a condition called Leber's congenital amaurosis. There's ways to test it electrophysiologically. And unfortunately, because I'm a pediatrician, I can't order some of those tests because only ophthalmologists are able to order that test. But I snuck up to ophthalmology. I got them to get this ERG done, and it was flat. And that tells you that it is Leber's, which is a genetic cause. So some genetic causes, the fundi look okay, or the optic disc looks okay. We have to try to find the reason, because I don't want to call you visually impaired unless there is a reason, right? So that's why patients get imaging if there's nystagmus. You have to find the reason for the nystagmus. Sometimes we can find it in the eye exam, but if we can't, maybe we should do imaging. Not usually if you're 6 years, because I do see patients with nystagmus long-standing for 6 years, but you're doing fine. The chance of you having a brain tumor becomes much less. But you can have all these different causes. And that's how traditionally it's defined. But if I talked about those causes, nothing of those causes tell me you're visually impaired, because I have patients with a whole bunch of different genetic, physical, structural abnormalities that don't meet the criteria according to ICD-11. So the points to consider when we're doing measures and diagnosis: one, what's the etiology? So if you know what things change over a period of time, you have to know, are you okay now? And you might develop something worse. Most cases are static, but we do have lots of conditions that are progressive. When am I doing the diagnosis? The younger, you're immature, you're younger, you haven't had an opportunity to practice using your vision, versus if you're older, you're mature, and then you've had opportunities to use your vision. So timing does matter. And then I do all the simple things, like when to do the assessment. There's a reason I do my assessments at a certain period of time. If I do it too late in the day, I am going to underestimate vision in most of the kids because they get tired. I have to do all the assessments in the morning, especially if they're coming from like Abbotsford. You have to think about when is the timing of when that assessment is going to be done. If you have seizures and they're sleeping, I can't wake them during their sleep. They are more likely to provoke seizures. There's timing of when this assessment has to be done. And then what is the environment? And that's why I've got the fancy lights in the back, right? I don't want light sources for the kids to look at. Okay, so now I'm going to just talk about other causes of visual impairment that I'm not going to really focus on, but this is a common thing that I do see. We have a problem in function. I can't do something. And they're associated with some neurodevelopmental disability usually. And then the question is, are you visually impaired? And then I go, oh, well, that's a question for Ram to answer. He's a developmental pediatrician and a neurologist. He should be able to answer that diagnostic question, right? Because now we're changing it. We're changing the goalposts for diagnosis. And this is a huge problem amongst the literature. People are mixing anatomical, acuity, functional criteria and pushing them all together. So most databases actually have this problem. They're seeing, oh, this patient doesn't perform well, has acuity if measured at 2100 or not even measured at all, has CP, I'm going to get them vision support services because that's an access point. It's registered in a school database, which is most of the states. The school databases are the ones that have who are visually impaired because they capture all this information. And so then you sort of go, oh, well, and they'll do a study on it, or they'll say, well, this is what the problem is. And then I go back and go, well, are they really visually impaired? Or are they have the same standard definition of visual impairment? And I would argue they probably do not. The next question we always ask is this: are you really impaired if you can function appropriately? Because that's the real question. And the good news for us in vision, that since we're ICD labelers, that's what we are, I get to see a lot of good function. And then I always sit back, wow, I had to write accommodation letters for a patient who's doing, a former patient, because now she's like 19, doing kinesiology at UBC, right? I started going, oh, that's like the things that I have to do. I go, oh, yeah, no, that's pretty good that you're able to do that. So I got a lot of little written notes for people going to university about what supports that they should get, or I have to fill out the PWD because you're legally blind, but you are functioning really well. So they get their pension while they go to high school, And then we always have this question is what's more important? Younger, I would say, I would talk about, let's try to improve the acuity, right? Because that's something that it's an anchorable type of thing. But now I'm more like, how can I improve the function? Despite what the acuity would be. But the threshold is that you have to have an acuity problem for me to even look at you, whether or not I want to try to do something about function. There is that difference between the two. Looking at time, good, I think we're getting close. So strategies. This is the less controversial, but maybe not as well studied problem. This is the best strategy, prevention. Because if you can prevent someone being visually impaired, that's way better. And I think this has been the most successful, because then I go like, how often do I see a patient with HIE? It's really a rarity now that I see patients with HIE. The severe HIEs, they tend to die. If you're moderate, you get cooling. They might have other developmental problems, because I can see more going like that, but they often don't really have a major vision problem. I don't see them as frequently. So that's great. We have immunizations. The only patients I see, the Canadian Deaf-Blind Rubella Association used to exist. They got rid of rubella. Doesn't exist. I only have 2, but they're all from outside the country. Nutrition. Unfortunately, we are now following a patient with vitamin A deficiency. Really sad story, patient with autism that eviscerated her right eye and created corneal clouding on the left. So she's now lost, well, she's now probably at light perception vision. Probably is not going to be able to get better than that. And then
Eviscerated.
poked out her,
Yeah,
they nucleated the right eye. The left eye hopefully can be managed, but the management of corneal disease in general is poor because, they'd have to put a transplant in, and a transplant is problematic because when you do that, the natural tendency is that you're going to rub it, and you can't rub it. Prenatal. So prevention is.
Vitamin A deficiency, congenital or acquired?
No, it was acquired because restricted diet. That's what it was. I thought Sharon might be interested in that patient. So the strategies for habilitation are really like you can think about in four quadrants. Restore the eye structure to the best that's possible. Improve the optics or improve the attention. And that's an important aspect, because then I always say that we're not really good at restoring in our realm. Restoring relies in the medical realm of ophthalmology. I could argue neurosurgery, it could be neurology, because all these things are restorable, whether it's by an ophthalmologist or by an oncologist or a neurosurgeon or a neurologist, because hopefully that the neurologist can optimize seizure control so that way we don't develop epileptic encephalopathies, right? In the future, it'll be genetics. There are several patients who are on gene therapy trials. There's some real big challenges about gene therapy trials in pediatric ophthalmology, because when do you do gene therapy? Like if you have no vision, you never develop vision ever, gene therapy may never work because you never taught your brain to see, right? So it may not be great for people with light perception vision unless you do gene therapy actually in utero or right at the time of birth, right? Because then you might develop that vision over a period of time. But the studies are not going down to that level yet. They're doing safety studies at older people before it gets down to the pediatric group. Optics are, yep. Yeah, it depends on the gene problem. Like it depends on what the gene defect will be. So there's stem cells, there are blockers or inhibitors, there are promoters. It depends on the underlying retina condition that you have, or technically also optic nerve condition, because there are a lot of gene optic nerve diseases as well. So it does matter, but the timing matters as well. So in order to restore something, either you developed it or you have to do it so early on that you can develop vision over a period of time. Because there's lots of anecdotal studies of patients who had cataracts removed but were never put in aphakic correction. They never learned to see in adults. So you can try to put glasses on them because they have structurally normal eyes. Their brain never learns to see. It's likely that if functional MRI studies probably will show that these areas in occipital cortex have now been populated with other neurological function. And so that means you probably do see something, like you might see light or color, but how do you understand form becomes a little bit harder.
But then I'm actually thinking not the congenital one, but for example, stem cell for optic nerve atrophies. So
yeah, often it depends on, yes, as long as you're able to see, but the problem about everything about vision system is everything's a domino effect. So if you lose a cell here, what happens to the one that attaches it to it? And so we think it's probably okay in lots of conditions, but it does matter when the event happened and how much vision you had. And that's why this window of when do you do it? Like were you visually matured, yes or no? And the other thing too about vision is really much more complicated, which we'll get to the very end, is having understanding of concepts probably matters more. And because if you understand something, then I can give you lots of cues and then your brain can lock in. That's why I commonly use the term apple. Now, if I said apple, all of you can now picture an apple in your head. That's how good it would be. So if I give you enough clues to think it's an apple, your brain will fill it in. But if you never know what an apple looks like, it's hard for the brain to fill in. So then conceptually, you don't understand, you can't match it. So the strategies that we use, or vision rehab services, tend to work on visual attention, which I'm going to say universally is agreed upon. And why do we agree upon it? Because we have evidence that it works in other circumstances. So one, vision's learned. We know that because they did bad things to cats and they looked at their occipital cortex when they did something bad, it never developed. And there are critical periods for that development to happen. We do that in people because amblyopia, the treatment is occluding the better eye for the weaker eye to improve. But it's not just the eye opening that makes that improvement. It's the using of the eye that makes that important, right? Because there are kids that they patch one eye and then they just do nothing. They just can't do anything because that asymmetry is really problematic, and they don't improve their amblyopia because they haven't used or practiced using their vision. And that's the real important part. They have to practice using their vision. And some of the strategies, when they say practice, I don't necessarily agree with. So some people just use a lighted toy. And then I go, well, if you're just looking at light, how do I know you're just not looking at the screen versus the details of the information on the screen? And so I'm not a big fan of lighted toys, although I'm okay if you told me that I know he's actually looking at the picture. And so that's why if you ask me, it's way better for him to tell me, oh, that's the best. Like he knows that's the video, or he can find the icon on the iPad. That's more meaningful because he's using the attention to try to see it. Visual attention, also, if I just looked at eye alignment, because when your eyes are crossing in, it generally is a sign of attention. And then just want to think about abilities. That vision loss early is problematic because you're at a critical time to understand things. So not having the concept really plays a big role. And concept development is age dependent. So everything I talk about is going, where are you? What are we trying to do to make you see and understand? Because once you know something, then I go, oh, that's way better because your brain will fill in all the other information. And then I say, well, how do I know your brain will fill in all the other information? I have to get to this. Here. Oh, sorry. Back. This back one. Okay. Well, anyways, I'm going to use your little form that you have in front of in the back. There's a dot and a pink X, right? Okay. Now, if you cover your eye, one eye, put the dot, you look at the dot and your X should be out here. About 2 feet away, that pink X should disappear. Remember, you're just looking right at the dot, tilt it a little bit down. Let's see here. Do you see, you got to move it back and forth. You got to find your blind spot. Find your blind spot. When you, so it might be 2 feet away, if your X should disappear because in your optic disc, you have no retina cells. You cannot see. So if you cannot see, that X doesn't appear for you anymore. Or the reverse, cover your eye, look around. Where's your blind spot? Right now, your brain is filling in that material. Or you're hallucinating. That's the other one, right? That's how powerful the brain is. It fills in material when you don't see it. if you've had visual experience. The funny thing about this piece of paper is that if I change this piece of paper to yellow, it would fill in its yellow. Or if I made it a pattern, it would fill in the pattern. If I made it a picture, it would fill in the picture. Because the blind spot, although it's big, you're able to fill it in. That's how powerful vision is, if you understand visual concepts. So then if you can do that, when you don't see something, you're functioning pretty good. And so I always go back down to, how do you see, how do you function? Because once you understand something, it's remarkable that your functional inability to do something becomes less. And so then people always say, well, who's functionally visually impaired? And I'm going to, this is a standard question that a vision teacher might ask. Are you functionally visually impaired? And I go, well, if you have a hard time doing these things, or you can't close that image that I just showed you, I go, well, I think you got a functional problem. But it's usually related to cognition, perception, lack of exposure. All those things play a role, right? It could be mobility, because I can't, get those experiences. So that's one of the challenges that we would have. And yet I'm not here to tell you who's visually impaired, who's not visually impaired. You guys can make your own decisions about doing that. If you refer to me, I'm going to tell you how I do it. Like, this is the way it would do it. I never untell someone you're not visually impaired if someone else said you're visually impaired. I just say you don't meet ICD-11 criteria for visual impairment, because that's a fact that you don't meet that criteria. It changes. It can change, because ICD-10, just like DSM, or 11, just like DSM-5 will change, because it constantly changes over a period of time. We just have to be up. I don't particularly like ICD-11 right now, because they've changed it into no more binocular visual acuity. It's only monocular. And I think there's a problem with it. And I think this is nearing the end. So I think that's everything. I can't move it forward. Oh, there it is. Goal is the functional vision. So I've left a bit of time for questions. Not very much time, I apologize. But I will take any questions that anyone else has. But remember, I don't have the answers to the definition of visual impairment. So. Questions? Comments?